Today, I am going to discuss an important topic that is management of ABO incompatible transplant. First of all, I want to discuss following three cases, which are transplanted in our centers. A 4 years old female patient diagnosis of beta thalassemia. She was 6x6 matched with her 9 years old female, while donor's blood group was B positive and recipient's was AB positive. And second, 8 years male patient, he was also beta thalassemia and 6x6 matched with her 11 years younger brother. A donor's blood group was A positive and recipient's was O positive. And third case, 11 years old male boy diagnosed of aplastic anemia. He was also 6x6 matched, her younger brother 10 years old, while donor's blood group was B positive and recipient's was A positive. So we will discuss and conclude all these cases at the end of our discussion. Now coming to the point onward, my presentation that will consist on following these objectives. That are overview of ABO mismatch hematopoietic stem cell transplant, selection of products and transfusion strategies, and complications and intervention associated with ABO mismatch, HSCT and their management. First of all, we know HLA and ABO inherited separately. HLA genes are located on chromosome number 6, which express on 200 genes. And HLA class 1 antigens are expressed on all nucleated cells, while HLA class 2 expressed on antigen presenting cells. And ABO antigens located on chromosome number 9, which expressed on red blood cells. Maybe patient and donor was 6x6 matched, but blood groups are different. So now basic concepts explains in this diagram. If recipients with blood group A, so antigens A are present on RBC's membranes, but anti-B antibody in their plasma. While patients type B have B antigens on RBC membranes, antibody A in their plasma. A patient with AB type have both antigens on RBC's membrane, but no antibody in their plasma. Finally, patient with type O, there is no any antigen on RBC's membrane, but both antibodies are plasma A and B. So anti-A and anti-B are naturally occurring antibodies that begin to appear in the gut flora. They are present in clinically significant levels by 12 to 14 months of life. 14 months of life. Now coming to what ABO incompatible transplant. ABO mismatch does not affect on engraftment, neutrophils, or platelets engraftment, or graft failure or rejection, since stem cells don't have ABO antigens. Like the lack of the ABO antigens allow for homing and engraftment of stem cells regarding ABO incompatibility. Now the ABO incompatibilities in the transplants. There are three categories in transplant, which are the major, minor, and bidirectional mismatch. Firstly, major mismatch is when recipient's plasma has ABO antibodies direct against donor RBCs. This is major mismatch. While a minor mismatch is when donor has ABO antibodies directed against recipient's RBCs. This is minor mismatch. And in bidirectional, both donor and recipients have antibodies directed against of ABO blood group antigens of each another. So this is bidirectional incompatible. Let's understand these concepts more deeply. When recipient's blood group same, recipients and donor blood group was same, so it is called identical blood group transplant. And while recipient is blood group A and donor with blood group O, it is minor mismatch because donor have antibodies and that are anti-A antibodies against recipients. And while recipients B or AB blood group and donor of type O, it is again minor mismatch because reason is the same donor has antibodies against recipients. When recipient is of blood group O and donor is of blood group AB or B, it is major mismatch. Recipients has anti-A, anti-B or anti-AB antibodies respectively against donor. Okay. Now coming to transfusion support for HSCT recipients. There are three phases. First phase, this is prepared for hematopoietic stem cell transplant until initiation of transplant phase 1. And phase 2, pre-transplantation phase, initiation of chemotherapy until engraftment. And in phase 3, post-engraftment, where forward and reverse group of recipient is consisted with donors ABO group. This phase needs some consideration. Let's discuss it. Now coming to transfusion support for hematopoietic ABO. Now coming to ABO selection of products. For major incompatibility, we can use PRBC transfusion with recipients type RBCs until recipient antibodies are no longer detectable. Then switch to donor type after this. And platelets and plasma continue with the donor type. And minor incompatibility, we can transfuse PRBC with donor type until engraftment, but platelets and plasma switch until recipients RBCs are no longer detectable. Then switch to donor type. And bidirectional incompatible, we can transfuse PRBC, provide O type, and platelets and plasma provide AB products. That is transfusion protocol. This is transfusion protocol. If recipient is a type positive type and donor is a negative, so transfusion would be negative with cells. And if recipients negative and donor as positive, transfuse the negative red cells and switch to positive cells once the transplanted bone marrow or peripheral blood cells, stem cells begins producing positive cells. Complications after ABO mismatch. And major ABO mismatch, all these complications occur because the cross-reactivity between donor blood group antigens and recipients. Immediately, complications are acute hemolysis of infused donor red cells within the graft and delayed hemolysis of red cells produced by engraft marrow recipients. ABO antibodies may be persist for 3 to 4 months and very delayed in onset of erythropoiesis 40 to 60 days. And pure red cell aplasia, reticulocytes persist greater than 60 days. Potential intervention for ABO incompatible transplant. Red blood cells, reduction of stem cell production 10 to 20 ml, and sometimes desensitization by donor type RBCs during conditioning days. A reduction in antibody titer of recipients using therapeutic plasma exchange. And diluting antibody titer of recipients by transfusing donor type fresh frozen plasma. Select and transfuse components compatible with donor and recipients. And minor ABO mismatch, immediate promotion of and minor ABO mismatch, immediately hemolysis of recipients erythrocytes caused by antibodies and transfuse donor plasma, and delayed hemolysis occurs 7 to 14 days after transplant due to rapid generation of antibodies by donor lymphocytes, passenger B cells against recipients RBC cells, and sesodial obstruction syndrome, isomegalutin of donor origin might attack censored endothelial cells, contributing to the development of a preventative hemolysis transplant. A continual clinical monitoring between day +5 and 15 for signs and symptoms of hemolysis, and including laboratory monitoring with LDH, bilirubin, and CBC DAT. And now coming to bidirectional ABO mismatch. And bidirectional ABO mismatch, immediate complication hemolysis caused by donor and or recipient's red cell antibodies, and delayed complications hemolysis caused by donor and or recipient's red cells antibodies. Delayed engraftment may be RBCs and pure red cell aplasia. Increased risk of mortality over major and minor mismatch. And see this. This is a simple diagram explaining steps to be and causes of complication causes of ABO mismatch transplant. If transplant is a major mismatch and patient's antibodies against the donor are equal to or more than 1:32. In this case, further intervention depends on methods of stem cell collection. If it is collected by a peripheral method, then RBCs needs to be depleted if product RBCs content is equal to or more than 20 ml. In case of collection from marrow, then RBC depletion needs to be done. No matter what RBC's content is, both of these are done by manipulation of product, which is to be minimized. That will also decrease the stem cell amount. Other technique can also be used, like therapeutic plasma exchange of patients with AB plasma to decrease antibody titer, are simply infused AB plasma or antibody donor type plasma to dilute. In case major mismatch and antibody titer equal to or less than 1:16, no intervention need. Now, if transplant is a minor mismatch and donor have anti-recipient's antibody equal to or more 1:256. So product manipulation, that is plasma reduction, needed to decrease the titer. In case of low titer, that is equal to or less than 1:128. No need for manipulation. Finally, in bidirectional mismatch, intervention need if anti-donor antibody equal to or more than 1:32, and if anti-recipient's antibodies are equal to or more than 1:256. And now coming towards the management of cases discussed with you previously. First of all, patient blood group AB positive and donor group was B positive. So pre-transplant anti-B titer of recipients was 1:128. In phase 2, she was transfused with B positive RBCs and platelets of AB group, and monitor DCT, LDH, and urine DR were checked on monitor on day 5 plus 10 and 15. There were no any findings of hemolysis or PLS, and blood group also converted to donor type. In case 2, patient blood group O positive and donor blood group was A. Pre-transplant anti-A titer of recipients was 1:256. So desensitized recipients with donor type, and in conditioning days and anti-A titer was repeated, then was 1:16. And phase 3 was transfused with O positive RBCs and platelets of A group. And monitor LFTs, DCT, LDH, and urine DR were checked post-transfusion of stem cells, and they were negative for acute hemolysis. And blood group also was converted in OPD and in donor type A positive. In case 2, patient blood group O positive, and donor blood group was A. And now coming to case 3, patient group was A positive and donor blood group was B. So pre-transplant anti-B titer of recipients was 1:32 and anti-A titer of donor was 1:64. In phase 2, she was transfused with O positive RBCs and platelets of AB group, and monitored DCT, LDH, and urine DR were also transfused stem cells, and on day +5, 10, and +15. There were no any findings of hemolysis or PLS. Blood group also converted and donor type. That's all. Thank you.
Thanks a lot, Ajit.
Any questions, sir?
That was that was very nice. I just want to make a comment on platelets. Now, of course, the choice of platelets is because you are concerned about anti-A or B in the plasma, not so much on the platelets, because platelets in most people will not express ABO, as you said. So they're largely expressed on red cells, but also the amount of plasma that you give by any donor is not very likely to cause major issue. That's why the at least in my view is that you don't need to be, while of course the blood type in terms of transfusion of packed cells is very important, the ABO type in platelets is much less important. And if you need platelets and you don't have the appropriate blood type, essentially you can give any type. So the rules, let's say, are less strict. That's my view. So, and
Okay,
also,
right.
I don't know, I'm curious, Ajit, do you often use single donor platelets, or you use mostly random donor platelets? In other words, from platelet phoresis or from...
Sir, we use mostly random donor platelets.
Okay, fine. Again, right, we don't really know whether one is better than the other. And the whole issue of platelet transfusion is really not very clear. Probably we give more platelet transfusions than we need. But anyway, okay, thanks a lot. Are there any questions? Now, I don't see Sandeep. Sandeep, are you there with somebody? Because you were supposed to give the next presentation. Ufika, is Sandeep with you? No, right?
No, sir, he's not with me.
Bina, you're in Nepal, so I doubt that Sandeep is with you. Yeah.
Yes, sir.
So I guess we don't have Sandeep. Well, I made a single poll on ABO and GVHD. So I guess we will postpone the poll to next time when also Sandeep presents. And so I guess we can, if there are no other questions or comments, I guess we can stop the meeting. So any questions?
No, sir.
No?
No.
Okay, then. Thank you very much.
Thank
Thank
you.
you, sir.
Thank you.
Thank you. Thank you,
Bye-bye.
sir. Thank
Thank
you,
you, sir.
Ajiz.
Thank you, sir. Thank you, ma'am.